Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a great honor for me to introduce Dr. Rick Miron. Rick is a dentist and a molecular cell biologist. He works at the Department of Periodontology at Nova Southeastern University in Fort Lauderdale, Florida. Rick, thanks for being on the show today, and really appreciate you taking my call and making some time for us today.
Thanks a lot for having me, for sure, without question. And so I'm really excited to be on the show and give more information on platelet-rich fibrin and some of the advancements I've made in research regarding this topic.
Yeah, so you've got a quite decorated background in education and training. I'd love for you to do just kind of a little bit of an introduction to yourself, some of your background, your training, your education, and then bring it up to speed with what you're doing today in your day-to-day, practice or life or office or teaching and all that.
Yeah, sure. So I've had a lot of experiences actually in research, which has helped me out a lot in my clinical practice. And so I started off actually as a scientist. And so when I was in high school, I had a mentor and I was doing a lot of science for projects, just small little jobs. And I continued down that track, but I always wanted to be a dentist. So I really liked my dentist in high school. And I've always wanted to become a dentist ever since I'm about 10 or 12 years old. And so part of my training, I did a lot of science. And then I actually did my first project as a master's student in oral implantology. And that was in Canada at the University of Western Ontario. And there I was studying things like surface topography. I was working a lot in collaboration with Straumann. And as most people know, Straumann's a Swiss company. And so when the project was completed, we published it in a pretty good journal. And they invited me to go do a PhD in Switzerland at the University of Bern. And I had many colleagues that were working there. Dr. Daniel Boozer, Dr. Tony Sculian, quite well-known school for implant dentistry. And I then spent 3 years there doing a PhD in molecular and cell biology. And all my training had to do with bone grafting materials and regenerative materials. After spending 3 years there, I came back to Canada and did a 4-year dental degree. And then after that, I went back to Switzerland in 2015 and stayed there for another 2 years, doing more research on things like platelet-rich fibrin and other growth factors. And so very recently, I decided to move back to Florida. It's been about a year now. And in Florida, the reason why I returned to North America is for the opportunity to do more clinical dentistry. So my license as a Canadian dentist is valid in North America, but not in Europe. And after these 2 years, I came back and started working in the Department of Periodontology at Nova Southeastern University.
Well, that sounds like quite a journey. I always thought that I could easily have seen myself go into molecular and cell biology research, because I really enjoyed that in school. I did a little time in some research labs at my university, and I really love that. But I also do love the hands-on doing the dentistry and all that. So it sounds like you found a way to blend both of those together, and those would be two passions of mine that I would have. Bone and anatomy, histology, and cell biology, and then actually doing the dentistry too. So it sounds like you've been able to blend those two interest into a career that's really fit for you.
Yeah, absolutely. And the nice thing about my job actually is that on even a week-to-week basis, I can really switch up what I'm doing. So if I want to go to clinic 5 days per week, it's something that I have the flexibility of doing. And then if there's a really hot research topic that's ongoing, well, I can spend more time there. I spend a lot of time lecturing also, so just teaching these new technologies. And so my lab is really built and set up both in Switzerland and now also at Nova, really to do FDA approval research for a lot of different companies. And so a lot of these things that we're testing are not actually commercially available yet. And they go through my lab, and we do the preclinical testing, both whether it be on cells or on animals, et cetera. And a lot of times we'll do the clinical trials, so the preliminary clinical trials. Often that's done in Switzerland. And so I get a lot of these materials that are really new to the average dentist. And it's really fun to be able to teach these dentists about these new technologies.
Yeah, that's frontline stuff, and that's what every researcher dreams to do, is be able to see it, use it, develop it, and then use it in the practice. So tell me about, I know you're doing some lecturing, you're doing some hands-on teaching, and then you're also doing some maybe practicing. of dentistry. So what is your schedule looking like these days? I know you're teaching a lot. You're in clinic. You're in an office. I mean, kind of tell me, break that up for the listeners what you're doing.
These days here, I'm doing a lot of research, and so basically, we made changes with Dr. Joseph Chakroun to platelet-rich fibrin, and he's a really clever guy. We're always improving the formulation. And so we teamed up with a lot of different collaborators around the world to do some more research on this topic. And now is really a pioneering time to really get into this field because a book company actually just asked me to write a textbook on this topic with Joseph Chakroun. And so we're the main editors. And I think it's going to be kind of widespread across every single university in North America very shortly. It's kind of gained a lot of momentum in the last 2 to 3 years, I would say. And so we've been pushing, really doing a lot of research so we understand it really at every level before it's being used consistently in every single patient that we're about to treat. So
how did you hook up with Dr. Joseph Chakroun?
Yeah, so it's actually interesting. So I'm Canadian, and so I speak both English and French, and I actually did my dental training at a French university. And he was coming every year to Quebec, in Quebec, Canada, where they speak French, and giving talks on this topic. And of course, my lab was doing a lot of research on regenerative materials. And so I understand the importance of angiogenesis, so new blood vessel formation, etc. And he gave a really phenomenal talk in some of these congresses in French, and I was listening to him. And in Canada, we decided to do some research on that topic starting in 2012. And I got together with one of my co-students, and we did a research project on platelet-rich fibrin with Dr. Vincent Guillemette. So he was somebody that did summer research projects with me. And then from there, it just kept going and going. And we started to see the potential of this platelet-rich fibrin. Then when I went back to Switzerland, I was back to my normal laboratory, so a much bigger lab and with a lot of big researchers in name. And then we really started pushing forward and dived really deep into this topic. And we published some really good papers. And it was funny because I got a phone call one day or an email very rapidly from Joseph Chakroun saying, "Hey, I just read your most recent article. It's really fantastic. Do you mind talking?" And within about an hour or two, he gave me a phone call in my office in Switzerland. And we talked for a little while. And then he invited me to Nice, France, and we started getting together and started planning a new research project and just kept growing and growing and growing. So right now, these publications and this newer centrifugation speeds have been really, really well received by academic people. And so I've been invited to lecture around North America, both in California now. I've been to New York, Ann Arbor at the University of Michigan, to Harvard, to Tufts. And so it's just a lot of people, a lot of academic people are really interested in this new platelet-rich fibrin. And I think it's going to be taught to most students. And probably it's going to grow very, very rapidly.
That's fantastic. Now, you're also doing some hands-on training courses. Is that correct?
Yeah, we do. And so that's one of the funny things with platelet-rich fibrin is that you actually have to draw and collect blood. So you need to be phlebotomy trained, let's say, in order to use this technology. And one of the funny things is that most dentists are actually scared to draw blood, or not scared, but we don't have this in our training program. And so, of course, every single person that wants to learn how to use platelet-rich fibrin has to learn how to draw blood and do phlebotomy. And we spend about 2 hours in every single one of our courses to really teach this, go over the technique. I always say to these dentists, 19 and 20-year-old nursing students learn how to do phlebotomy when they're in nursing school, and then they do it routinely. It's not very complicated. It's much easier than doing, let's say, freezing certain areas in the mouth. And so we go over the protocol for phlebotomy training, and then, of course, where and when to use PRF is the most important thing. So there's certain indications where it works very well and predictably. There's others where you have to be a little bit careful.
Okay, well, that sounds like you're really busy. So
yeah,
there's a lot of my listeners that probably don't know, what PRF is and maybe what the whole concept of this platelet-rich fibrin and what's being done in implant dentistry and bone dentistry and all these things today. So if you could break it down for me, talk to a clinical dentist right now. Don't talk to a research dentist. Talk to a clinical dentist on that level, if you would. What exactly is PRF? And then after that, we'll talk about, how does it work? Like you talk about where to use it, how to do it. But let's just start with the basics. What is PRF?
Sure. So it's blood proteins. So it's growth factors that are found in blood that are centrifuged to reach super physiological doses of growth factors that can then be reused for regeneration. And so it stems from a lot of previous work that was done on PRP, so platelet-rich plasma. And a lot of people know and have learned about platelet-rich plasma. And when I go to conferences, a lot of people know PRP. Oh, yeah, I've heard of it. I might not use it. PRF is very similar but you remove the anticoagulants. And so the way that it works is that Professor Marks actually in Miami developed and did a lot of research in the late 90s and early 2000s on PRP. And what he found was that you can actually collect blood, centrifuge it with anticoagulants, and then use the PRP in combination with different biomaterials to help with regeneration. Now, within some time afterwards, we found that the anticoagulants were actually inhibiting wound healing slightly. And so Joseph Chacroun was one of the pioneers to invent a new technology which required anticoagulant removal. And so the nice thing about PRF versus PRP is that it's completely natural. So you basically collect blood, you spin it down and centrifuge it, and it's going to form a little fibrin clot. And that fibrin clot contains all the growth factors. It's typically done in the upper layer of these tubes. Now, the one disadvantage about PRF is that you have to spin right away. So if you wait too long, of course, coagulation will occur because there's no anticoagulants anymore. And you need to have the machine ready. You need to have it in your office. You need to be phlebotomy trained, and you need to basically collect the blood, spin it down, and then you can use that as a matrix later on for various dental procedures.
Yeah, so for a dentist listening, maybe you've seen pictures of this. The PRF is when you're taking the blood and you're spinning it down in a centrifuge, and it separates between all this red blood material at the bottom and this big white
fibrin clot.
Big white fibrin clot at the top. You're separating that white part off the top, and that's what you're using now for your growth factors, for your bone regeneration and your healing cascade, correct?
Exactly. And so there's three principles to tissue engineering. You need a scaffold, you need cells, and you need growth factors. Those are the three most important things. Now, with the fibrin clot, now you get a fibrin scaffold. So when you separate these PRF and you centrifuge, you get about 4 milliliters where the PRF is contained in 6 millimeters of the red blood cells. Now, the red blood cells are typically eliminated from the PRF clots because they actually don't induce regeneration. What induces regeneration is typically white blood cells, so leukocytes. So a lot of people get confused. What's the difference between PRF, or some people have heard of LPRF, for instance? That stands for leukocyte platelet-rich fibrin. So around the year 2006, 2007, 2008, around that time, we started to understand that it was actually the white blood cells that were helping with regeneration, so the leukocytes, and it was later renamed from PRF to LPRF, and that can be used for regeneration now.
So now we kind of understand a little bit more of maybe what PRF is, and let's go into a little bit more of how exactly it works. So let's just take anywhere in the mouth where you're wanting to help grow bone or regenerate bone or help the healing of bone. How exactly does this work? So you need a scaffold, and you need cells, you need growth factors. Is that right? So how does PRF work maybe in all three ways?
So the advantage of having the PRF scaffold is that now it contains leukocytes. And these leukocytes are continuously secreting growth factors. So basically you have a PRF matrix now. You're taking autologous tissue, so it's blood from the same patient, obviously. These cells are then alive. They're spun down. They're collected in higher numbers. And because there's higher numbers, they're also secreting higher number of growth factors. So this fibrin, a lot of people compare it to actually a snot clot. So that's a nickname for it, it's a snot clot. It looks like a snot clot, and you can use this actually to, let's say, place it in extraction sockets. You place it in an extraction socket, and it improves wound healing because you're introducing vascularization to that tissue with all these growth factors. So the reason why it's used very frequently in implant dentistry actually is that whenever you extract teeth, you lose your periodontal ligament, and the periodontal ligament contains most of your source of blood supply. So whenever you remove the periodontal ligament, you're losing 80 to 90% of your blood supply, and therefore you're going to lose a lot of bone quite rapidly. If you introduce PRF with all these blood-derived growth factors, it's like you're maintaining a blood supply to that area while it's regenerating. So it's very, very favorable for extraction sockets and around implants where you don't have your PDL anymore.
Yeah, that's great because the biggest problem is in implant dentistry is having the right amount of bone and having the right quality of bone and getting to grow bone. And so this is kind of like a super not a drug, but a technique to really enhance all the things that we're trying to do. Walk me through the kit and how it works exactly. So I know if I bought my PRF centrifuge and the instrument kits and the syringes and all that. Tell me how this actually breaks down for a dentist in their clinical office. I mean, like you were going through, it's got to be done right away. It's, there's certain things that are important. Kind of walk someone through, okay, I've got, all this stuff that I just got, and I'm looking to introduce this to my practice. What does that look like? Walk someone through A to Z, how to get that ready.
Okay, so first you need the centrifuge, obviously, and that's the most important thing. And you need the centrifuge, obviously, because you're not using anticoagulants. And this is very, very different than PRP. And a lot of people get confused with this concept. So many clinicians were using PRP before. The tubes had anticoagulants inside them. So you could actually collect the blood. You can send it to a lab. They can walk back 15 minutes later with the PRP. That's no longer possible. So very, very important is to have the centrifuge ready, open. And certain machines have settings that you're going to use. So on the newest centrifuges, and these are provided by Frontline Dental, there's a setting for advanced PRF, which makes the matrix, and iPRF, which is a liquid version of it. And I can explain what both of these are later. What you're going to do then is obviously collect the blood. So you're going to get everything ready. You're going to have the tubes ready, the tourniquet ready, the butterfly needle ready. You introduce the butterfly needle, and you start collecting the blood as a normal procedure. Once you collect the blood, you immediately have to place them into the centrifuge. Once they go into the centrifuge, they have to be obviously well balanced. So you have to have exact same number of tubes inside the centrifuge, which is approximately the same amount of liquid in each tube. You centrifuge. So the new protocols now are 1300 RPM for 8 minutes, and these are already pre-programmed on the machine. So you just turn it to APRF and you get that stat. Afterwards, you pull out the tubes, and a fibrin clot will typically form in the upper layer. If you don't have a fibrin clot, all you need to do is remove the caps and wait 5 minutes. Within 5 minutes, then you have your fibrin clots that are being formed. Now, there's a difference, too, that people need to understand is that you need to use glass tubes for the fibrin clot formation. So the glass tubes actually help making this clot faster. So then after these 5 minutes go by, you have a fibrin clot in the top layer. You remove these, obviously, with you can remove these and then place them in the box, the PRF box. Then you have many options what you want to do with these PRF. So you know now that you have a PRF membrane, and you can use this for regeneration. You can use it for plugs. So you can basically compress them and make these tiny little plugs that you can fill extraction sockets with. You can flatten them and make board barrier membranes. So you can essentially replace collagen membranes in certain indications. And you can use them, let's say in the sinus. So you can cut them up into small pieces, mix it with the bone grafting material to improve angiogenesis of your bone grafting materials. So from there, there's many, many indications of how you can use this PRF scaffold.
Yeah, so that's great. There's not like, hey, this only works in this one substance. I mean, you can replace grafting material by putting these directly in the socket for like a socket preservation. You can use these to cover grafting materials like a membrane, or you can use these adjunctively to cut up bone, cut up, this snot clot, this PRF, and mix it with your bone and add that to increase volume and increase healing. So there's multiple uses, multiple places in the mouth, and any indication that might need increased bone healing, you could introduce this in some manner or fashion.
Yeah, absolutely. And the best way, if you've never used PRF before, is that there's a ton of videos on YouTube. Just go on YouTube or on other platforms that display videos. Many clinicians are using it nowadays, and there's some excellent videos that are kind of beginner training for how to use the PRF membranes. Sure.
Now, who do you feel like would benefit from this the most? I mean, if you're a general dentist and you're just taking out teeth, and you're like, I'm not really placing implants yet, but maybe I want to, and I'm just pulling teeth and maybe learning how to bone graft. Maybe that's one dentist, or you're another dentist and you think, okay, I'm placing some implants, but I'd like to, increase my game. Or if you're somebody who's placing a lot of implants, who do you see using this the most? Is it the new guys? Is it the old guys? Is it the young guys? I mean, what do you see as far as, who should be using this and on what indications?
Yeah, so there's a really defined, I think all dentists basically that are doing extractions can use PRF. So it's very, very straightforward. I mean, if you're going to place a collar plug or you're going to place a bone grafting material, there are indications where you can replace those with PRF essentially. And more dentists are noticing that the effects are advantageous for the simple fact that it's increasing angiogenesis to a lot of these tissues. And also it's very low cost. So you're essentially replacing the cost of a bone grafting material in many indications with a PRF membrane, which is collected from patients' own blood, which is just the overhead cost of the dentist is only $1 or $2 for each one of these tubes. So, there's many different indications. I'd be more than happy to talk about where we use it specifically. And so if you have 4 walls, for instance, on an extraction socket, you're taking out a normal teeth in the premolar or molar regions with 4 walls, you can easily take these PRF membranes. You compress them. So in the kit, there's an actual piston and cylinder. So you place the PRF clot in these little cylinders, and you basically just take the piston and scrunch, compress it. And then you take these compressed PRF membranes and you place them in the extraction socket. Now, the nice thing about this is that because it contains so many of your own body cells, and it contains a lot of leukocytes and macrophages fight off infection. So you don't need primary closure. You can actually leave these PRF membranes exposed to the oral cavity, and it will actually reduce infection. So some studies have shown that actually, for example, for third molar extractions, there's a lot of infections, a lot of dry sockets. Typically in the literature, this is reported around 10%. I would say 10% on average, sometimes higher, sometimes lower. Whenever you use a simple PRF clot and you place them in third molar extractions, you completely eliminate dry sockets. So the percentage goes down to 1% or less in every single study that's been performed so far. So there's huge advantages there. Now, whenever you're doing regeneration of, let's say, the sinus, for example, well, if you're going to do a sinus augmentation procedure, people need to understand, and dentists understand, that it's a very low vascularized area. So that's the reason why if I want to place an implant, let's say, in an extraction socket, I might have to wait 2 months or 3 months and then I place my implants. Many times if I have a sinus that needs a big augmentation procedure in your sinus, you're having to wait 6 months, 8 months, 10 months. You're having to wait a long time. Why are you waiting a long time? Is because you have low vascularization. So there's not a lot of blood flow going to that area in the sinus. As a result of that, new bone formation takes place a lot less. New bone formation is decreased. And the advantage here is that if you just cut up a simple PRF membrane and you combine it with your bone grafting material, you increase angiogenesis. So you're increasing blood flow to that area now. New bone formation takes place faster. You can then place your implants in those areas faster. So that's, you can shorten regenerative procedures by using this PRF membrane.
Yeah, that's great. Now, there's 2 things you keep coming back to, and that's, angiogenesis and blood supply and decreased infection. I mean, those 2 things alone are probably the biggest benefits that you see. And also, like you said, cost for the patient, cost for the dentist. I mean, you've got to think something coming out of somebody's body is better than something coming off of a dry shelf. So, there can't be a lot of downsides to this. What would be a downside if there were to be any? I mean, are there any drawbacks in using this technique?
Yeah, sure. I mean, there's drawbacks to every single procedure, and that's the reason why in our course we really explain specifically where and when you can use it. You can combine it with most biomaterials. One of the problems that was seen very early on is they were trying to do it for basically everything. It started working for extraction sockets alone. They said, oh, wow, let's try it for sinus lifting procedures alone. Let's try it for, Miller class 3 gingival recessions alone. Let's try it for a whole bunch of things by itself. It doesn't always work when it's used alone. And so it's very important to understand where and when you can use it. So I'll give you the perfect example. In a sinus elevation procedure, if your sinus is 10 millimeters or less in width, you can place your implant there. You can pop a few PRF membranes up there. You'll have 100% of the time regeneration. When that sinus becomes wider and wider, so if it gets to be bigger than 15 millimeters in width, you can no longer use PRF alone because it doesn't hold enough stability. So the PRF membranes, they typically degrade within 10 to 14 days. So in about 14 days, that PRF membrane will be gone. And when we have wide sinuses, one of the problems is that we place our implants up there. Actually, you don't know what side all the time the PRF membrane is going to stay on. So it's it'll stay in that area. But if it gets degraded very, very rapidly, sometimes new bone formation in these wide sinus hasn't taken place enough. So we recommend if the sinus is 15 millimeters or greater, you need to combine it with a bone grafting material in those instances. For example, in another case, if you're doing a Miller gingival class 1 Miller gingival recession or class 2, no problem at all using PRF alone. If you don't have enough keratinized tissue, however, you need to use a connective tissue graft. And so a lot of clinicians and periodontists, they try to replace completely connective tissue grafts with PRF. It works in many indications without question. It's not entirely predictable in Miller Class 1 or in very limited keratinized tissue. So these are the areas, they're like gray zones. Sometimes it works, sometimes it doesn't work. But we want to introduce and teach dentists, obviously, procedures that are going to work predictably basically 100% of the time.
Sure. And it's not that it doesn't work, but it can't do everything. I mean, like you said, the sinus lift, maybe you have to mix it with bone, but you could decrease the amount of bone that you're having to use, and it also kickstarts the healing and the blood flow. So it's not that it's going to solve every problem, but it's going to decrease a lot of other auxiliary grafting materials that are needed. It's going to kickstart that healing and kickstart that angiogenesis, and so it's going to add predictability and shorter and better outcomes than if not done. Is that correct? I mean, are we seeing quicker healing times and better healing times as a result of this?
Yeah, sure. So in general, as long as you're improving blood flow to a tissue, of course, you're going to get faster wound healing. And that's a huge advantage with the PRF. So it can always be combined with different biomaterials and improves wound healing. It's to know when you can use it alone versus when you're combining with another material. Now, a lot of clinicians are using it with basically every single procedure. They're either saying, okay, I'm going to use it alone, or I'm going to use it in combination, and that's for basically every procedure that they're going to perform. So anytime you're raising a flap, for example, the nice thing about using this PRF membrane, imagine if you're doing a typical guided bone regenerative procedure, you're going to augment with the bone grafting material, and then you're going to place a barrier membrane over top of that, and then you're going to close your flap. Well, imagine if that flap, for whatever reason, is slightly open, or there's too much tension on that flap, for example. If you have a small little opening, the bacteria from the oral cavity, when they get in contact with these barrier membranes that are made out of collagen, for instance, they get infected quite frequently, right? Surgical procedures are very, very important in those larger GBR procedures. If instead you use a PRF membrane, the nice thing about the PRF is that it can actually be left exposed to the oral cavity. So it's going to improve soft tissue faster, but it can be left exposed because it has all these white blood cells and these leukocytes that fight infection. So if there is a small little hole or one of my sutures lets go, the bacteria come in, they're in contact with the PRF membrane now with all the host-fighting leukocytes. So that prevents the infection. So that's where there's a lot of advantages that way there.
Yeah, that's great because, like you said, in those grafting areas, you've got to get that tissue closed, and, you've got to get it closed perfect. You can't stretch the tissue, but you don't want it to hissing and opening, and reinfection or loss of bone graft material have to be the two biggest, things that you've got to be worried about. So this PRF membrane helps hold the bone in better and protects from the infection while that closure time is most important, in those first 2 to 3 weeks. That kind of seems like a no-brainer for those procedures.
Yeah, absolutely. And the soft tissue wound healing is really where the big advantage is. And so this fibrin clot can turn over much faster into soft tissue wound healing. And if there's keratinized tissue around, it improves keratinization. Now, in implant dentistry, for instance, we've learned over time, all the research was always focused on hard tissue formation. How do we get faster integration? And we've learned actually that in order to have hard tissue formation, you need soft tissue formation, and especially for long-term stability of your implants, and vice versa. So if you don't have hard tissue formation, it's very difficult to get soft tissue. And if you don't have soft tissue that's being formed around your implants at the time of implant placement, you're exposed to greater risks of having things like periimplantitis, et cetera, which is becoming more and more of a problem, actually. So PRF is very, very often used in implant dentistry by just placing the PRF membrane around the collar of your implants. And so what you can do with these membranes actually is you can flatten them. So imagine you take this fibrin clot, you flatten it like a pancake, and then you punch a little hole through it. And this is called the poncho technique. So now you have a little hole, and you can actually take the PRF membrane and wrap it around your implant, around your abutment, around your implant shoulder, and then you close your flap. Now, the nice thing about this is that you have all this fibrin matrix around your entire implant. And that will dramatically help with regeneration around your implant very, very quickly with very low chance of infection.
Yeah, I think that's a big thing you talked about. Everybody talks about bone stability. Well, I've found that, the tissue stability and the tissue attachment and the health of the gum tissue, is probably your biggest indicator in implant dentistry, and it's probably the least amount of talked about thing. So I'm actually glad that this is really coming into play because if you can heal the tissue around the bone and the implant, assuming you get it in the right spot and it's got enough bone density, the rest of it's going to take care of itself. So you've got to take care of that that exposure point, that initial healing area, that tissue development, and that is vastly important for your long-term stability of your implant.
Yeah, absolutely. That's the biggest indication actually in implant dentistry is for soft tissues, without question. Now, there are people that are using some of the liquid that's produced from the PRF. So they're using, whether it be injectable PRF, or you can take these membranes, let's say, as you're squashing them down, obviously some liquid is coming out. And this liquid actually contains a whole bunch of adhesion proteins. So fibronectin is a perfect example. You can actually take this liquid and dip your implants inside these liquids. Some people have tried it to help with osteointegration. And they can use these liquids, to help with. Some papers have shown that it works. Others show that there's very limited additional benefit. Implants nowadays, I would say the osteointegration of titanium implants are so good and so high that, you don't need much improvement there. But in the soft tissue around these implants, you can really have a tremendous benefit there. And more and more clinicians should really be aware, take care of your soft tissues on implant placement, the day of implant placement.
Yeah, so even if you're not needing that liquid on the implant, you might still be able to add it to your bone material to hydrate your bone material with, and probably have enhanced handleability and kind of almost like making sticky bone, right?
Yeah, exactly.
So that's going to help hold your bone graft in there better. And then if you're putting the membrane on top, that's going to hold it better. And then, you've got multiple layers of defense against the attacking bacteria from the mouth and the insults that injury area has to, overcome in its healing cascade.
Yeah, definitely. And, this goes in line very well with two indications that have been more and more brought forward by a lot of researchers, and this is really pioneered in Europe. Now, bisphosphonate users and diabetic, these are two indications where PRF is almost used systematically for almost all indications. And it's very interesting, actually. I was talking to a collaborator in Germany, and now if a patient's been on bisphosphonates for 5 years or longer, they actually have to have primary closures after extraction. So imagine you're pulling out these teeth in this elderly patient. Maybe they don't want to have implants. You must, it's part of their protocols in clinical practice, raise flaps in these patients and then have primary closures in order to prevent osteonecrosis of the jaw, which we all know is becoming a bigger and bigger problem. Now, some researcher in Germany also said, okay, well, if this is the case, why don't we simply, instead of raising these flaps in these patients, just put PRF plugs inside these defects? And they've basically shown that they can eliminate bisphosphonate users' osteonecrosis of the jaw by simply placing PRF scaffolds in there. That's one big indication where I think probably in North America, more and more people will adapt these techniques because it's so easy and it completely eliminates your risk. And the last thing you want as a dentist is to have a bisphosphonate user for 10 years come back to you with osteonecrosis of the jaw and know that you could have simply put a PRF membrane in there, which is basically costing you nothing, and prevented the problem completely. With diabetic patients, it's the same situation. A diabetic patient, what's the problem with diabetic patients? It's blood flow. So in my diabetic patients, I know that I already have less blood flow. As a result of having less blood flow, I also have less resistance to infection or more infections in diabetic patients because their wound healing properties naturally are a little bit lower than the average person. In these patients here, imagine I can take the blood, I can centrifuge it to have super physiological doses of leukocytes, and these leukocytes will help fight infection. So imagine if I have to do a GBR procedure tomorrow in a diabetic patient, it should be almost mandatory to place these PRF membranes prior to closing my flap. Because if there is an exposure, this diabetic patient has a higher chance of infection. If I simply add PRF membranes there, the rate of infection goes down dramatically. So these are two indications I think a lot of clinicians and implant dentists should really consider.
Well, that's great. I think all the evidence is pointing to this being better, for your patients, better outcomes for the dentist. And I think that's really all anybody wants. How can you get better healing? How can you get better results? How can you get more predictability and keep people out of trouble? Yeah, I'm really excited. Now, I just bought my whole PRF kit from Frontline Dental. I think last week I got it in the mail. So I am super excited to get this thing out and get it ready and use it. I've got all my parts out. I've got it sterilized. I got it ready to go. Now, if somebody was wanting to get started, how should they do that? Should they go to the course? Should they Should they just get the machine and get going? Do they have to come to a course that you're teaching throughout the country? How do you recommend people jump into this thing? I'm just going to give it a whirl. My wife's a nurse. I'm going to have her draw the blood on the first couple of patients while I kind of practice on my skills. And then I'm just going to jump into this thing. But for someone who says, I haven't drawn blood since dental school, or, I'm not sure about this whole centrifuge thing, what's the best way so they can, get in touch with somebody who they can talk to or get some more information and kind of get, the real scoop on this?
Yeah, I think the first thing you need to know is to understand what you're involved with, obviously. So when you're using a new instrument or a new technique or a new growth factor, such as platelet-rich fibrin, to really understand everything about it before you start using it. So you need to really be aware of where it works and where it doesn't work. For extraction sockets, for example, with 4 walls, you can go ahead tomorrow, extract a tooth, have your assistant, as you mentioned, draw the blood, spin it down. As long as you're using the right centrifugation protocols, it's no problem at all to take these membranes, compress them, and then place them in the extraction socket, draw up a little X suture, and away you go. You'll see the wound healing, the soft tissue will heal very, very rapid. For more complex things, such as the sinus, in intrabony defect regeneration, in gingival recessions, around implants, etc., probably a little bit better to know where and when it's going to work. And that's where I would probably recommend taking the course. The courses are 1 day. So it's in 1 day, we teach the whole procedure, including drawing blood, so phlebotomy. And you'll really get a lot of information. And the other thing that I provide for all people that are taking these courses is that I give them a Dropbox link with all the publications on PRF. And so there's about 500 papers on PRF. And what I did with a group of experts, we had 20 people, and most of these people actually helped writing the book. So they each wrote parts of different book chapters. We separated every publication on, let's say, for example, extraction socket healing, furcation regeneration, intrabony regeneration, around implants, around the sinus, around immediate implant placement. So I have all these publications on this topic, and they're all separated. So you basically get all the papers that have ever been published for clinical use on this topic all in one folder. And then they're all very clearly laid out, and then you can read them afterwards. That would probably help most people out tremendously. So it is, there's a lot to learn. We just wrote a textbook. It's 295 pages, right? And this has to do with the 500 publications in the literature. So it's very difficult to just say, okay, I'm going to hop right into it and be going full speed. Probably better to slow down a little bit, let's say, and get the education that you need before you start using it.
Yeah, I agree. I just jumped in and bought the thing, but like I said, I haven't started using it yet because I know that I need more on it. So I'm going to start with some of those clinical, publications and find a course that fits, the time frame that I'm looking for. Now, where does someone go for courses? Is it the PRFEDU.com? Is that correct?
Yeah, that's we have an advanced PRF education program, and so the website's www.prfedu.com. And there we have about 20 courses per year. So I'm about 2 per month on most months. And it's a 1-day course. We go around the country. I do this with Frontline Dental, obviously, who partnered with us and have been a tremendous amount of help with Dominic Marino, who's been one of the lead guys for the company. And we teach this systematically, very, very high quality, and we go over every single clinical indication that you can use PRF for. So by the end of the course, I really want to make sure that people don't use it inappropriately, let's say. And I think that's something that Dr. Joseph Chacroun has really pushed. He's been a big mentor of mine without question. And of course, for him, he invented it. And when he invented it, they started using it for many, many different indications. And he always says to me, the last thing that I want is for people to use PRF in a wrong indication because it's going to damage my reputation. The problem is if you go out and you use it, let's say, for a sinus augmentation procedure alone in a large defect, you might have high hopes that this stuff is going to work great. And then when you have a failure, you might associate that failure with the PRF. You say, oh, this stuff doesn't work. It damages, obviously, all of our reputations, all of us teaching it, et cetera. So we really are very strict on teaching where it's going to work predictably. In pretty much all indications, and where it's not going to work. And where it's not going to work is the important ones.
Yeah, obviously this isn't a fix-all thing, and you have to know what you're doing. So there's probably a learning curve. Start small, learn how to do good draw, blood draws and centrifuges. Start with just some of the basic extraction sites, and and monitor how that does with your hands, and then kind of expand from there. So, for me, the courses seems like a no-brainer. It's like I can read stuff all day, but I just assume go listen to you live and pick up the information direct, see it, and get it that way, because I know that, being there is the best way to learn it. So, I mean, that's got to be the best way to learn, I would think.
Yeah, absolutely. I think so too. And like I said, there's a lot of little tricks that you can learn in a course that you might not figure out on your own. And so one of the nice things is that I'm actually teaching also with Dr. Mike Picos in his institute. So he's located in Tampa, Florida, and he gives some of the best courses I've ever seen on advanced bone grafting and sinus elevation. And in these courses, even me, who's been doing a lot of research with PRF, I still learn things from him. So I teach the basics of PRF, and then he teaches a lot of the hands-on stuff when it comes to using PRF also. And together, these courses are really, really well run. And so a perfect example is he always says, every single time that I take out a connective tissue graft, now what he's doing is he's taking one of these PRF membranes and he places it inside the palatal holes, basically, right? He can fill these sites up with PRF membranes. And the nice thing is that there's actually some research that's been performed where they actually looked at patient pain and satisfaction after these connective tissue grafts that were harvested. And they found that patients report taking less medication and also report less pain just by placing these PRF membranes. So we all know that if we harvest connective tissue grafts, of course, this is painful for our patients. When we have to do it, so there are indications where we absolutely have to do it, you can usually just take these PRF membranes, pop them in these sites, and wound healing is faster, of course. Patient's taking less medication, patient is happier, and patient is reporting less pain and swelling. I mean, it's also a no-brainer, right? But I didn't learn that until I took this course, so that's a perfect example of it. Another thing that people are doing too is, sinus tears, for example, are quite common. So imagine you're doing a sinus elevation procedure. If you're opening a lateral window, the chance of tearing your membrane, even though some people think it's very low, it's actually in the 20 to 40 percentile. So 20 to 40% of the cases are resulting in these tears. Most of the time, you don't even see them, right? They might be a small little 0.5 millimeter or 1 millimeter tear. When you use PRF, actually, one of the recommendations is actually to take these PRF membranes and just pop them on the Schneiderian membrane. And they stick there. They'll be resorbed within 14 days. You can usually place 2 membranes there. And it's basically a protection against your bone graft if you have to use it, right? So you can place now, instead of using, let's say, a tear and you use a collagen barrier membrane, now you can use a PRF membrane for free, right? It costs $1 or $2. You're just using it. You're placing it there. You're protected. You place your bone graft. You're completely safe. You can place your implant at the same time. No worries, because you got this cushion, this snot clot that's going to help you. Now, this has become very, very commonly used, let's say, in the crestal approach, right? How many people are doing crestal approach now instead of lateral approaches? Many, many dentists have switched over, and a lot of these techniques are very, very good. But imagine this Schneiderian membrane is 0.5 to 1 millimeters in thickness, right? So what are a lot of people doing that are using PRF? They take one of these membranes, they spin it down, they collect it, and then they just place the membrane inside the crestal approach. So they're just popping the membrane up there, and it's basically just acting as a cushion. Now I can place my implant up there. If I have torn my Schneiderian membrane, which might happen, it's very difficult to know, obviously, when you're doing the crestal approach. But either way, you place this membrane as a safety thing. It's like a little tent that's floating up in your membrane. You then place your implant. If you need a bone graft, great, even better, because now the bone graft is protected by the PRF membrane, so it's not in contact with this slight little 0.5 to 1 millimeter Schneiderian membrane, and it's like a protective agent, let's say. Yeah,
I mean, that's, anytime you can have a barrier against that membrane that also induces healing and bone formation, I think you're just, your outcomes are only going to get better and more predictable.
Yeah, and safer, right? So you're less complications, and that's the big one for all clinicians. I mean, we want less complications.
I mean, at the end of the day, that's what we're going for: peace of mind and predictability. So anything I can do to improve that, we'll be better off. So places and resources for people to go, so they can check out the courses at PRF. So www.prfedu.com. They can also check out maybe where to buy one of these at frontlinedental.com. Is that correct?
Yep, exactly. Yeah.
Okay. And you're at the courses, the equipment's at Frontline Dental. Is there anything else anybody needs to know about, any information or anything else that someone might, a resource to point them towards, or are those two sites, pretty well intuitive with that?
Yeah, those two sites typically we have everything that you need to know. So on the PRF EDU website, we give a little explanation about what PRF is, what the advantages are, obviously with wound healing, decreased rate of infections, and I actually post some of my publications up there also. And so you can download some publications for those that don't really know what it is or want to learn more. They're on there, and there are also videos on the Frontline Dental page. And so he's got some videos up there of it being used in clinical applications. You can find a lot of information. And then once you come to the course, like I said, it's a one-day course. From there, you get every publication ever published on PRF. So you can basically read for days and days and learn every indication you want to. And you can just keep expanding your skills.
Rick, I really appreciate your time here today. Your knowledge is ever expanding, and you probably know more than you could share in 1 hour, but I think you did a good job of presenting it in a way that makes sense. I definitely look forward to seeing you at one of these PRF courses probably this summer. I've got a lot going on this spring, but I'm going to try to make one out this summer. And, definitely encourage anybody to try to catch you out there at one of your courses. Anything else that, if anybody has any questions, where could they get a hold of you at?
Yeah, so my email address is rmiron, RMIRON, at Nova, NOVA, .edu. So that's my university email. And also, if anybody has questions about the courses or locations, etc., that can be found at info@prfedu.com.
Well, thank you for your time. It's been a pleasure speaking with you. I love this information. I'm really excited to get started and look forward to seeing you at a course here soon.
Yeah, definitely. I mean, if you have any questions yourself about when to use it and how you're using it, et cetera, just shoot me an email and I'll definitely answer them. And that goes the same for all your listeners too.
Excellent. Well, thank you so much. Appreciate your time, and we'll catch you again, okay?
Yes, perfect. Thank you. Thanks for having me on the show.
Have a great evening. Thank you.
You too. Bye-bye.
Bye-bye.